Internal diseases lecture for students first study year. Acid associated diseases, symptoms, syndromes, and disease states. Acid associated diseases in ICD classification 10 includes gastroesophageal reflux disease, functional gastric dyspepsia, gastritis duodenitis, gastric duodenal and gastrojejunal ulcer, symptomatic pathological hypersecretion like Zollinger-Ellison syndrome, hyperparathyroidism, and other endocrine disorders. Symptoms, syndromes, and disease states such as heartburn, abdominal pain, etc. Gastroesophageal reflux disease. Definition: GERD is a condition in which the reflux of stomach contents causes troublesome symptoms and/or complications. Troublesome symptoms. In conducting population studies, mild symptoms with a frequency of 2 or more days per week or moderate severe symptoms with frequency of more than 1 day a week. In clinical practice, whether the symptoms are causing concern must determine the patient. Endoscopic gradient degree of esophagitis by Savary-Miller. First stage: single erosion, red spots and stripes around the Z-line, erythema, or areas with reduced vascularization. Second degree: stretch non-circular erosions with hemorrhagic tendency. Third grade: the trend towards the spread of circular erosions, no strictures. Fourth grade: ulceration or erosion with strictures. Fifth grade: metaplasia, intestinal metaplasia, named Barrett's esophagus. Barrett's esophagus. Other classification of reflux esophagitis, Los Angeles classification. Stage A: single erosions lower than 5 millimeters in diameter. Stage B: single erosions 5 and more millimeters in diameter. Stage C: erosions include about till 75% of round of esophagus. And stage D: erosions more than 75% of round of distal part of esophagus. Here see variants of metaplasia in different endoscopic systems. Classification of Barrett esophagus, Prague classification. There are two parts of this classification. First, circular, C, distance from the highest line of metaplasia from location of gastroesophageal junction. And C, it's circular metaplasia in centimeters. Treatment of gastroesophageal reflux disease. Rule of Bell: the healing of erosions in the esophagus occurs in 80–90% of cases if it is possible to maintain a pH more than 4 during the day for at least 16 till 22 hours. In case of non-erosive gastroesophageal reflux disease or endoscopically negative variant, proton pump inhibitors in the standard or double dosage one time per day in the morning before meal 4 till 8 weeks. Erosive variant of gastroesophageal reflux disease or endoscopically positive proton pump inhibitor standard dose of 8 weeks in stage A-B and till 12 weeks in stage C or D. GERD with extraesophageal manifestations like such as chronic sinusitis, chronic pharyngitis, proton pump inhibitors in double dose till 16 weeks. Next, disease dyspepsia. According to translation from Greek, pepsis digest, this disorder, dyspepsia, digestive disorders. It's a not rare disease in the world, you see on this picture. Variants according to Roma criteria, postprandial distress syndrome and epigastric pain syndrome. Roma criteria for diagnosis of dyspepsia. One or more characteristics of disturbing or unpleasant feeling after eating, rapid saturation, epigastric pain, epigastric burning, and lack of data on organic pathology, including endoscopy, which could explain the occurrence of symptoms. The criteria to be observed for at least the last 3 months of the start of symptoms, for at least 6 months prior to diagnosis. Diagnostic criteria for postprandial dyspeptic syndromes. One or both of following criteria. A feeling of fullness that occurs after taking the normal amount of food for at least a few times a week. Rapid saturation and therefore cannot eat regular food until the end of at least a few times a week. Confirmatory criteria may be swelling in the upper abdomen or nausea or excessive belching. As a rule, there is no epigastric pain. Diagnostic criteria of epigastric pain syndrome include all pain or burning sensation localized in the epigastrium of at least moderate intensity with at least one time per week. Periodic pain. No generalized or localized pain in other parts of the abdomen or chest. There is no improvement after a bowel movement or flutters. No eligibility, gallbladder disorders, or sphincter of Oddi disorders. Confirmatory criteria. Pain may be burning but without retrosternal component. Pain usually appears or conversely decrease after meals but may also occur on an empty stomach. Postprandial distress syndrome is generally lacking. The alarm symptoms, which exclude usually functional disorder, unexplained weight loss, the repeated vomiting, dysphagia, odynophagia, signs of anemia, signs of gastroduodenal bleeding, lymphadenopathy, palpable epigastric mass, a history of stomach ulcers. If patients older than 45 years old with newly developed symptoms of dyspepsia. Early endoscopic strategy in patients older than 40 years old in Europe and in US increase the frequency of detection of early cancer of all diagnostic cancers from 1% till 26%. Treatment of dyspepsia. Basic drug at all variants of dyspepsia are PPIs. It's possible to start a treatment with non-absorbable antacids, short course, or use beta blockers, H2 histamine blockers receptors in standard dosage. In the case of H. pylori associated dyspepsia, uh, can assign eradication schemas according to international recommendation named Maastricht Consensus. When postprandial distress syndrome added prokinetics in standard dosage for 2 or 4 weeks or other drugs that affect the symptoms of the disease, for example, non-absorbable antacids. Lack of effect of the treatment should alert the doctor in the availability of organic disease in the patient and the need for additional diagnostic procedures, especially if patient has alarm symptoms. Acute gastritis, variants catarrhal, corrosive, phlegmonous, fibrinous. It's separate isolated allergic gastritis and gastroenterocolitis that develops with food poisoning, and the inflammatory process involves not only the stomach but the intestine. The mainstay of treatment of acute gastritis, functional rest of the stomach, which is achieved to the greatest extent in the appointment of proton pump inhibitors. In allergic and infections etiology based therapy, elimination of pathogen or allergen. Chronic gastritis. It's a chronic inflammation of gastric mucus. Uh, must be verification by biopsy and morphological examination. And it's necessary to check the Helicobacter pylori infection. Classifications include morphological variants, OLGA, operative link of gastritis assessment, and OLGM, intestinal metaplasia, such morphological systems to determine the degree and stage of chronic gastritis. Sidney Houston classification of chronic gastritis. Types of gastritis: acute and chronic, non-atrophic, atrophic, and special forms, for example, lymphocytic, granulomatous, eosinophilic, chemical, radiation, infection gastritis. Topographic, antral, fundal, and pan gastritis. Activity and severity of gastritis. The degree of atrophy must be established. More comfortable for this is morphological OLG system. Treatment of chronic gastritis include eradication of Helicobacter pylori in case of Helicobacter associated gastritis, or symptomatic treatment like in case of dyspepsia. With the progression of atrophy and metaplasia dysplasia, when the multiplicity of endoscopy with biopsy is increased to 4 times a year, and in severe dysplasia, mandatory counseling patients oncologist. Maastricht consensus for treatment of diseases associated with infection H. pylori. First line therapy. Proton pump inhibitor in standard dose twice per day. Clarithromycin half a gram 2 times per day. Amoxicillin 1 gram 2 times per day. Or metronidazole half a gram 2 times per day. If it's region with high level of resistant strains of H. pylori, more than 15% in population, first line may be quadrotherapy with bismuth salts, such like uh, quadrotherapy proton pump inhibitor, bismuth 120 milligrams 4 times per day or 240 milligrams twice per day. Metronidazole half a gram 2 times per day. Tetracycline 500 milligrams 4 times per day. Course of treatment preferring 14 days, 2 weeks. Here you see changes of gastric mucus in chronic atrophic gastritis, like cancer cascade by Pelayo Correa. It's now established that the bacterium is the cause of H. pylori chronic gastritis, the most important factor of pathogenesis of gastroduodenal ulcer, gastric multilymphoma, and gastric distal cancer. In 1994, experts of the International Agency for Cancer Research named H. pylori cancerogen first class. Peptic ulcer, it's the disorder between aggressive and protective factors in stomach mucus. Here you see endoscopic picture of ulcers, peptic ulcers. Treatment. Treatment of peptic ulcers includes elimination of etiological and damaging factors, eradication of H. pylori infection, etc. Blocking of reduction of aggressive factors of gastric juice. Of course, it's uh, proton pump inhibitors, H2 histamine blockers, antacids, cytoprotection, normalization of gastrointestinal motility in case of reflux gastritis, and symptomatic treatment like in case of dyspepsia. Complications of peptic ulcers: bleeding, perforation, penetration, perivisceritis, gastric outlet obstruction. The possibility of reduction, the frequency of relapses, and the successful treatment of refractory ulcers, eradication of Helicobacter pylori infection, cancel of non-steroid anti-inflammatory drugs, prokinetics in case of reflux, increase the dose of hydrochloric acid secretion blockers, 2-3-fold dose of proton pump inhibitors, for example, and maintenance therapy. symptomatic pathological hypersecretion, and symptomatic ulcers. In the case of symptomatic ulcers, drugs, stress, endocrine, for example, Zollinger-Ellison syndrome, hyperparathyroidism, etc., is most important to the elimination of the etiological factor, adequate treatment of the underlying diseases, the blockade of secretion of hydrochloric acid, like proton pump inhibitors using or H2 histamine blockers. Acid-associated symptoms, syndromes, and disease states in the primary care seeking as a more precise definition of pathology is not available for any reason and the patient is considered to be satisfactory, may conduct an empirical treatment before the investigation. It's necessary to check the intensity of symptoms by validated scales, for example, like Likert scale, you see on this picture. Treatment antacids, alginates, H2 histamine blockers, proton pump inhibitors, prokinetics, antiemetics, rehydration. If the symptoms not reduced after 2 or 4 weeks of treatment, it's necessary hospitalized patient or um, investigation. In any case, the doctor should give aware that this diagnosis is not likely to be final and conduct an adequate investigation with the patient according to the existing protocols. In particular, this applies to elderly patients, especially if the symptoms first appears in nearest term. Treatment of acid-associated diseases. The basic approach, antisecretory therapy, H2 histamine blockers, proton pump inhibitors, in additional short course of antacids. The rule of 3, 4, 5, 6. pH more than 3 to treat ulcers, dyspepsia, maintains treatment of gastroesophageal reflux disease. pH more than 4 for the treatment of gastroesophageal reflux disease, non-steroid anti-inflammatory drugs gastropathy. pH more than 5 to eradicate H. pylori successfully. pH more than 6 for the treatment of gastroesophageal reflux disease with extraesophageal manifestations and in case of gastrointestinal bleeding. That's all.